Hi, welcome to the webinar. My name is Dr. Robert Reiter. I'm a professor of urology at UCLA School of Medicine, where I'm also the director of the prostate cancer program and the head of the division of urologic oncology or urologic cancer. So I'm here today to talk to you about really an evolving and very important topic in prostate cancer that I think is very relevant to many people, many men who come to see us in the office today. And the topic is how we integrate new types of imaging, that is X-rays, as well as genomics, that is the study of genes present in cancer, in the management of patients with prostate cancer. So you can ask questions on Twitter using the hashtag at UCLAMDChat, or you can make comments on YouTube, and I'll answer your questions at the end of the presentation. So prostate cancer is a very common disease. It's actually the most common cancer diagnosis in American men. There are approximately 180,000 new cases diagnosed each year in this country, and it's the second leading cause of cancer-related death, with 29,000 people unfortunately expected to die from prostate cancer this year. But prostate cancer is complicated. It has a very variable natural history, ranging from completely benign and non-life-threatening to very life-threatening. And there's been a very significant controversy about prostate cancer screening, which I'm sure many of you have been reading about over the years, particularly the use of PSA screening. And this controversy comes about from the fact that this is such a heterogeneous disease with very different behavior, and the concern that some men get overtreated for this cancer, that is, men with very indolent types of cancer who perhaps don't need treatment. So luckily, over the last few years, there's been a huge amount of innovation, much of it coming from UCLA and our groups at UCLA, as a way to essentially solve this conundrum of how do we identify men who are at risk of dying from prostate cancer and treat them early, and how do we avoid over-treating other men who perhaps don't need treatment at all. And so what I'm going to talk about are some of these new diagnostic and management tools that we have. There's actually every day an increasing number of both urine and blood tests that we can do. There are tissue-based tests, that is using tissue obtained from a biopsy. And then there's a whole range of new imaging techniques that are out there. And I'm going to focus today on the use of MRI imaging, which is the main one that we use for the detection of prostate cancer. So the two questions I'm going to address today are, first of all, who needs a biopsy? So among men who have an elevated PSA and are referred to us, not all men necessarily need a biopsy. So how can we actually improve the detection of cancers that require treatment and perhaps reduce the number of unnecessary biopsies that are done, which historically might have detected cancers that perhaps are best left alone and not detected? And then once a diagnosis is made, how do we decide who actually needs treatment versus who doesn't need treatment? So I'm going to talk about how we integrate imaging techniques and all of these urine and blood and tissue tests into addressing these two questions. And so that's the topic. And again, the goal of all of this is to reduce the problem of overdiagnosis and overtreatment, and at the same time to guide appropriate treatment, deciding whether treatment needs to be intensified or de-intensified for any individual patient. And so by doing these things, we think that we are beginning to solve the problem of overdiagnosis and overtreatment, which is making PSA screening less controversial. And in fact, the American Task Force, which previously did not recommend PSA testing, is now saying that PSA testing, at least with proper guidance, is actually advisable. So the outline of the talk, I won't have time to go over all the tests that we have today, but I will focus on a number. So for the first part of the talk, I'm going to talk about what tests can we do to determine who actually needs a biopsy and actually how to guide the biopsy when it's done. So I'm going to talk about multi-parametric MRI, which is really probably the major innovation in this area over the last 15 years. I'm going to talk about blood tests, some simple ones such as what's called PSA density. I'll mention some others called 4K and SelectMDx and I'll focus on one of them just to give you a sense of how we can use them. And then I'll actually provide kind of an algorithm about how I go about making decisions about who requires biopsy and then who requires treatment. And then I'll talk about the tests that we use to determine who actually needs treatment after a diagnosis has been made, who might be best managed by what we call active surveillance, which is simply monitoring men, but without any immediate treatment because of a very low risk of succumbing from this disease, versus those who actually might need even more intense treatment. And I'll talk about the use of MRI, which can be used both to determine who needs a biopsy, but also can help us in determining who needs management. And then I'll talk about one of the three actually tissue-based, what we call biomarkers that can be used to help assess the risk of any individual cancer and help the doctor and the patient make a decision about who needs treatment. And those, I'll principally talk about one called Oncotype DX, but not to say that there are not other valuable tests, but to give you all an idea of how we use these tissue-based tests to help us make diagnoses. So first I'll talk about MRI because that's going to be a big part of the conversation today. So what is MRI? So we call it multi-parametric MRI, which because we are measuring, when you get the X-ray or the MRI, we're not simply looking anatomically at what's going on. We're actually looking at functional characteristics of the tissue or the organ, the prostate, that can actually help us discriminate between areas that are cancerous versus those that are not cancerous. And among those areas that are cancerous, which ones may actually require treatment and which ones may not. So MRI combines what we call multi-parametric MRI, combines what we call T2-weighted imaging. That's just the anatomic picture of the prostate. It includes something called diffusion-weighted imaging, which measures the ability of water to diffuse through tissue, with the concept being that cancer cells are tightly clustered together compared to normal tissues, and therefore water cannot diffuse through them. So the larger, more densely packed a tumor is, the lower the diffusion. So we talk about diffusion-weighted imaging. And then the final parameter we measure is called perfusion imaging, which is essentially a measure of the blood circulation through a given region in the prostate, because cancers, tumors, have a larger number of blood vessels and a very aberrant supply of blood vessels that can actually be visualized by giving dye and watching it traverse through the circulation into the organ. So using multi-parametric MRI, we can locate a suspicious area, we can measure its size, and as I'll show from work done largely at UCLA, we can actually assess the aggressiveness of a tumor simply by an MRI. Now, when your doctor talks to you, he's going to talk to you, he or she will talk to you about how we actually assess an individual lesion that's seen on an MRI. We use what's called a PIRAD score. And this is basically a scoring system that assesses the risk that anything abnormal in the prostate is or is not cancer. And just so you get an idea, PIRAD 5 means there's a very high likelihood, high suspicion of cancer. PIRAD 1 and 2 mean a very low suspicion of cancer, or we might actually just call that a negative MRI. But PIRADs 3 and 4 are somewhere in the middle between those two. And these things have significant impact on what we do. So this is just a picture of the different sequences that they use. I'll just focus on 3. So just to get a sense, this is actually a prostate here in cross-section that I believe I removed from somebody a few years ago. And then you can see the tumor here highlighted in green. And if you look at the MRI, what you can see is, so if you look at, this is called the T2-weighted image, and this is the prostate here. And normally it should be white and bright like this, but you see this area where there's no brightness, and that correlates with the presence of this cancer. On diffusion-weighted imaging, normally you should see white again, but in areas where there's low diffusion, often it will be black like this. So that implies low diffusion. And then finally here is perfusion-weighted imaging. You can see that there's an increased signal from blood vessels in the area of the tumor. So this would have gotten a score of what we call PIRAD 5, a highly suspicious lesion, and indeed it turns out to be a fairly aggressive form of prostate cancer. This is called spectroscopy, which we don't use as much these days, so I won't go into that. And again, this is the system, PIRAD 1 through 5. There are characteristics that the radiologist uses to assess any area that looks abnormal. And then ultimately, you put all that together and you get a suspicion score, which we call PIRAD score, with 5 being the most suspicious, 4 being of intermediate suspicion, 3 being relatively low suspicion, and 1 and 2 essentially being negative, what we would call a normal MRI. And how do we use this? So if your doctor orders an MRI as your first test, or perhaps you've even had a negative biopsy in the past, but the doctor is concerned you might have cancer, we can get an MRI, and if there's an abnormal area that's seen, we can actually now target that on a biopsy. So there are 2 ways that that can be done. The most common way is what we've been doing at UCLA now for over 10 years, which is to do what's called a fusion biopsy. And what a fusion biopsy is, essentially we take the MRI image and we superimpose it on an ultrasound image done in the office, and then we can highlight the area of suspicion, and under direct visual guidance, we can actually put needles directly into this area. And as you can imagine, this is a more accurate way of doing a biopsy, because historically what we would do is we would just take an ultrasound and we would just do a series of biopsies from around the entire gland, but without the ability to really see any suspicious area. So we would call that essentially a blind biopsy. And what we know from history is that we would miss as many as 30% of significant cancers by doing this blind technique. So this is really revolutionizing how we do biopsies. There's debate about whether this should be done as part of a first biopsy in all men, or whether this should be reserved for men who have had negative biopsies in the past. Generally speaking, particularly at UCLA, we're doing this in almost all instances as the first diagnostic test and the first biopsy. And this just shows the way this works. We've got a machine that fuses, 2 different types of machines, in fact, that fuse the images of the MRI and the ultrasound, allowing us to sample this area. And then in this patient, this is after the prostate was removed surgically, for this tumor that you can see, or this lesion you see here, and you can see it correlates very nicely with where the tumor is on the prostate specimen. And so this is how it works. Now, there have been a number of very large studies in our field that have essentially validated the utility of using MRI for patients who have a high suspicion of prostate cancer, getting an MRI, and if there's a suspicious area, doing a fusion or targeted biopsy of this area. And this is a randomized study that came out of, essentially done throughout Europe and the US, which showed that depending on what the PIRAD score is, 3, 4, or 5, the incidence of finding significant cancer among those patients. And as you can see, if a man had a PIRAD 5 lesion, 83% of those men had a significant cancer that most likely requires treatment. Whereas if you had a PIRAD 3 lesion, 67% did not have any cancer. So you can see the correlation of the PIRAD score simply with the presence of cancer. And what they were able to show is this was a randomized study of men undergoing a standard biopsy versus those undergoing an MRI first, and then those who had suspicious areas undergoing biopsy. And importantly in the study, men who had a normal MRI did not undergo biopsy in general, and I'll come back to that point in a minute because it's an unanswered question. And what you can see is the group who had MRI, even though fewer of them actually had a biopsy at the end of the day, 38% of them had a significant cancer, and only 27% in the group who had the standard evaluation, suggesting that by using MRI, we can both increase the detection of cancers that should be detected, and at the same time reduce the total number of biopsies, or men who need to be biopsied. And this is consistent with many other results, and consequently in many parts of the world this has become standard of care. In the US this is becoming more and more common. Certainly at UCLA this has been our practice for a number of years. Now at UCLA, what we've done over the last almost 15 years is, because we started our program with MRI so many years ago, we've been able to essentially correlate our ability to detect cancers by MRI with what's actually present in the prostate, determined at the time that the prostate is removed surgically for those who elected surgical removal. And this is a complicated slide, But basically what it points out, this was published in the journal European Urology by our group just this year, but it's a study of 800 men who had MRIs, biopsies, and then had their prostate removed. And we looked for what was the detection rate of MRI for the presence of cancer. So MRI is not perfect. It doesn't detect all cancers. And what this shows essentially is that if you look at this is the big number here, 80% of cancers were detected by MRI, 20% were not. And depending on the cancer, the rate of detection was higher or lower. So the way that we look at prostate cancer is by something called the Gleason Score. Gleason 6 is a very indolent, slow-growing tumor. We also call that grade 1. And Gleason scores 4+3 and higher, thought to be quite aggressive tumors, and those are also called grade 3 through 5. And the higher the Gleason score, or the higher the grade, the more likely it is that MRI will see it, which is a good thing, because we want to find the bad tumors. We don't want to find the good ones. And so you can see for the low-risk tumors, what we call Gleason 6 or grade 1, only 20% of them could be detected by MRI. So this itself is potentially reducing the number of tumors that are overdiagnosed and consequently overtreated. So this is a powerful tool, but always important to recognize that no single test is perfect and that some cancers are not detectable by MRI. And so that raises the question about, let's say you came in to see us, your PSA was elevated, we did an MRI, and the MRI was normal, didn't show anything. So on the one hand, you could say, well, I'm done, I don't need to do anything, I don't need a biopsy, but we know that MRI is not perfect. And so this is a study that was run by my partner, Dr. Lenny Marks at UCLA, where we did essentially just standard biopsies and MRI-guided biopsies in a large cohort of men, and that included biopsying men who even had normal MRIs. And what we found is that 15% of the men who had a negative MRI still had significant cancer, but we found that you could use a very simple marker to identify the men who were at higher risk of having cancer despite a negative MRI, something called PSA density. PSA density simply means your PSA level divided by the size of your prostate. So if you had a PSA of 4 and you had a prostate that measured 20 grams, which we can measure accurately by ultrasound or by MRI, you would have a PSA density of 0.2. And what we know is that higher PSA densities are associated with cancer, lower PSA densities are not. And indeed, among the men who had a negative MRI, a PSA density greater than 0.15, there was a 36% chance of a significant cancer, whereas if the PSA density was lower, only 8% did. So we can use this very simple biomarker, integrate it with the imaging, to give a risk assessment of the likelihood of having cancer or not having cancer, and thereby reduce the number of men who may need a biopsy, particularly those with a negative MRI. And I'll talk about another test that we can also use to help us with this decision making called SelectMDx. And so this is the test called SelectMDx. SelectMDx is a simple urine test. The doctor has to do a massage of the prostate for about a few seconds, and then a patient gives a urine sample, and we send this off for testing. This measures the presence of different genes or RNAs present in the urine that are associated with cancer. And it performs quite well in detecting the cancers that we want to detect. And it also performs very well in identifying those men who don't have cancer. So there's something called the negative predictive value, which is basically the prediction of the absence of something. And SelectMDx has been shown to have about a 95 to 97% negative predictive value. So if you had a normal MRI, let's say, and then you had a essentially normal or negative SelectMDx urine test, we could be pretty darn certain that you do not have prostate cancer. Whereas a high SelectMDx, despite a negative MRI, would indicate the presence of cancer. So this is the key number, is this 98, 99% negative predictive value. This is from one study. Overall, it's about 95 to 98% negative predictive value for the presence of significant prostate cancer. And this just shows something called the area under the curve. This is how we measure the performance of a given test. And essentially, the further the curve is to the left, the better the test is. And so what one can see here is that SelectMDx outperforms some of the older tests that we used to use that we no longer use, and also outperforms certain risk calculators that we can use that incorporate age, PSA level, family history, things like that. So this is a very helpful test that I use quite often, and it's one of a number that are now available in this setting. And this just shows the correlation of this test with the Gleason score, the aggressiveness of cancer. So this is a kind of an algorithm. This is not, written in stone, but this is basically how I go about thinking about men who come into me with an elevation in their PSA blood test or a strong family history. The patient comes in. If I have a high suspicion that that patient might have cancer based on that thing I said, PSA density, or perhaps they had one of these blood or urine tests before, like SelectMDx, if that's high, then I'll go ahead and I'll get an MRI. If the MRI shows an abnormal area, whether it's PIRAD 3, 4, or 5, then what we'll do is go ahead and get a targeted biopsy, that is the fusion biopsy that I talked about. If it's positive, then we'll go on to the next step, is does that person need treatment? If it's negative, generally I believe a negative result is negative. Every once in a while, if we have a very high suspicion, we can send that biopsy specimen off for a specific test called ConfirmMDx that can assess the chance that we actually missed something. So we've got tests and biomarkers for essentially every condition that we might meet. If the MRI is negative, if I have low suspicion, that is low PSA density or a negative SelectMDx or a negative 4K, it's another blood test that we can do, then we stop at that point. We just monitor men's PSA. If they're still suspicious, based on PSA density or whatever, we might just do a routine biopsy, the old blind biopsy that I talked about, or we might use one of these biomarkers here and then use that to make a decision about biopsy. So there's many ways that one can go. Alternatively, if a patient comes in and honestly I have a very low suspicion that that person has cancer, their PSA may be high but it's not changing, not rising, or the PSA density is very low, instead of going to the expense of an MRI, I may go ahead and just get a urine or blood test and assess risk that way. If it's negative, I'm pretty sure a person doesn't have cancer and we can avoid doing it. So once a patient has a diagnosis of cancer, then the next question is, should that patient be treated? And then the secondary question is, how should that patient be treated, which I'll probably talk about in a different webinar. But today I'm going to focus on just what do the different tests that we have tell us about that cancer once it's diagnosed, and how do we use the imaging and the biomarkers that we have at our disposal to make decisions about or make assessments about the risk that the tumor that a patient has might pose a threat to that patient's life and best be treated either with regular therapy or even intensified therapy versus those who perhaps are better suited to what we call active surveillance or monitoring. So here we have a number of different tools. We've got the conventional tools, which I would call, which are simply the blood test, PSA, the size of the tumor based on the biopsy, and the Gleason score on the biopsy. Those are what we would call conventional clinical tools, which we've had for some time. But now, in addition to that, we have the multiparametric MRI, which, as I mentioned at the beginning, has utility both as a way to detect and biopsy prostate cancer, but also provides additional information about the size of that tumor and the risk of that tumor, which I'll get into. And then here we have additional molecular tests called tissue-based tests, where we're measuring a number of different genes or profiling genes present in the tumor that are correlated with the aggressiveness of that tumor. I'm going to focus today on one called Oncotype DX, but there's another one called Polaris and another one called Decipher. There are pros and cons to each of these, but my purpose today is to really describe how we integrate imaging and biomarkers to make these decisions. So I'm going to talk about, this is a fairly typical case. So the first case is a man who was 65 years old, had a PSA of 5. He actually had a biopsy done outside of UCLA and came in with 2 biopsies showing Gleason 6, a very low-risk cancer, and there was very little cancer in each of the biopsies. So this patient had not had an MRI yet and had not had any tissue-based biomarkers either. So the first question is, could we actually do an MRI, and could we use that to assess whether the patient truly is low risk and should be on what we call active surveillance, or whether perhaps that traditional biopsy missed something more aggressive that might have been picked up on an MRI and should either be re-biopsied or the patient recommended to move directly to treatment. And again, this comes about because our standard biopsies will underdiagnose, understage cancers in about 30% of men. So when it comes to MRI, there are a few important concepts to recognize. As I said, it measures not just where a tumor is or a lesion is, but something about the aggressiveness of that tumor. So this is a publication from our group from quite a few years ago. And what it does is it correlates what's called the diffusion score, which I mentioned at the very beginning, with the final Gleason score, that is the aggressiveness on the biopsy or in the prostate specimen. And it basically shows that the lower the diffusion, the higher the Gleason score. So low diffusion rates were associated with Gleason scores 4+3 or higher, whereas high diffusion or normal diffusion, almost like normal tissue, was associated with lower risk cancer. So as a general principle, if somebody had a Gleason 6 tumor on a biopsy, and then had a lesion on MRI that was read out as having a very normal diffusion, I would think that there's a good chance that indeed this is a low-risk patient who should be monitored rather than treated aggressively. And this is another study from another institution that basically looks at can we add the PIRAD score from an MRI to all of the other features that we know from a biopsy to classify patients appropriately. And again, these are area under the curve graphs, or ROC curves, what we call them. And the blue is essentially the use of MRI plus everything else can improve the prediction of what's really going on. That is, the Gleason score being higher, the cancer going outside of the prostate, just unfavorable prognosis based on following men for a long time, or just the amount of tumor. So the use of MRI certainly provides more information than just the location of a cancer, but it really can be used to help assess risk and make recommendations about management. And this is a study from our group. My fellow Dr. Faena just published this in the Journal of Urology. And what we did here is we looked at a group of patients who have what we call low intermediate risk cancer. That is, many of those men will live with their cancer and not die from it, but there is a subset who are at risk from dying. And we simply asked, is there a way to use MRI, or does MRI correlate with the ultimate outcome of those men after treatment? And what we showed is, this is a curve showing essentially not survival, but the likelihood of a recurrence of their cancer. And the bottom line here is are PIRAD-5 lesions. Those are MRI classified PIRAD-5 lesions. And the top are either not visualized or PIRAD-3. And you can see men who had a lesion that was classified as PIRAD-5 had higher risk cancers. They had a higher risk of recurrence, even despite treatment, than those who had either a normal MRI or had a PIRAD-3 lesion. And then PIRAD-4 was somewhere in the middle, as you would predict. So this shows that PIRAD scores on an MRI provide, even among men who have the exact same Gleason score on their biopsy, that it provides more information about risk. So I'm very cautious if I see a man who has a 3+4 tumor and a PIRAD-5 lesion. Either I recommend rebiopsying that through a fusion biopsy, or I recommend active treatment. There's controversy about this, but we've got significant data to back this up, and my own experience of doing this for the last 15 years. So that's MRI. So do we have any other tools at our disposal that can help us assess what the true risk is, particularly for men who have low risk cancer or intermediate risk cancer on their biopsy? Is there anything else besides MRI that we can do, and can we integrate all these things together? So as I started to introduce, there are these things called tissue-based biomarkers. So this implies that we take the biopsy that was done and the area of cancer on that biopsy, and we do what's called DNA and RNA profiling or sequencing. And we use the constellation of genes present in that tumor to predict the actual risk of that cancer. So this is one such test called Oncotype. It's also referred to as the Genomic Prostate Score. That's the score that you get when you send this off to the lab. It's called the GPS score. And what it is a 17, it's essentially a profiling of 17 different genes that are associated with different biological pathways in the prostate. And you can take even a minute amount of cancer from a biopsy, a millimeter, and you can run this assay. And this assay predicts for the likelihood that the tumor either is more aggressive than anticipated or less aggressive. And I'll explain that further. So this is what the test was designed to do. I'll put this all together like that. So what they did is they were looking for a series of genes that would predict for the presence of a more aggressive tumor, and that was characterized by what was found at surgery, that is what we call the pathological stage and grade. So if a tumor on biopsy was rated as a 3+3 or 3+4, grade 1 or 2, but ultimately at the time of surgery it was found to either extend outside of the prostate, which would be called stage 3, or to have a higher Gleason score, 4+3, that is a grade 3 or higher tumor, then that was considered an upstaging or upgrading of the tumor that would be predicted for by this test. So the GPS score predicts for the likelihood of having either more advanced disease, that is a tumor that grows outside of the prostate, or having a higher grade tumor defined as grade 3 or above, or Gleason 4+3 and above on the older system. And what it does is the following. So for any given man who comes into the office, if we have the biopsy information, the PSA, the age of the patient, all of those traditional factors, we can actually categorize the patient as being very low risk, or intermediate risk. But we know that not all very low risk patients on biopsy are truly very low risk. Some are higher, some are lower. And by the same token, those with intermediate risk, some of them have even a higher risk and some actually have lower risk. So the goal of this test, the GPS test, is essentially to stratify that risk. So for any given individual, depending on what their GPS score is, you can say that they have anywhere from a 20 to an 80% risk of having adverse or bad pathology, that is the risk of a bad outcome. And you can do this for any risk category that you give to a patient. So the patient comes to me like the one I started out with a Gleason 6 tumor, very small amount. Traditionally, we would say that's a very low risk patient. And if I got a GPS score on that patient and it came out at 60, I would say, you know, you probably you may not have a very low risk cancer. You may indeed have a more aggressive tumor based on this prediction, and it's been shown to actually predict for the presence of adverse cancer. On the other hand, if the patient comes back with a very low GPS score and everything else says very low risk, that person can be assured that they have a very low risk tumor and can go on to active surveillance. And so that's how we use this test. So the next question that came up is, and that we've been working on, is how do we integrate the different things that I've just told you about? How do we integrate the MRI image and this GPS or these tissue-based tests? So we did publish a paper also last year in the Journal of Urology that looked at a group of men who had had surgery at UCLA, had an MRI prior to their biopsy, had a fusion or targeted biopsy like I mentioned, and we also got an Oncotype test on them, a GPS score on all of them. And we asked whether or not the Oncotype tests provided us even more information that we could glean from the MRI. And the bottom line is that yes, it did. So even in men who had an MRI lesion that was biopsied and it came back as Gleason 6 or 7, there was still a chance that tumor was either more or less aggressive than it looks like under the microscope, and that this test, the GPS test, could predict for that. And this is the probability that this is a correct answer with a probability of 0.001. So this is a statistically significant predictor of adverse pathology, even in men who have an MRI. So we can integrate all of these tests together. And this is what's commonly done. And this just shows that that there is a correlation between this GPS score and the PIRAD score. I already told you that PIRAD is associated with worse disease when it's high. And indeed, overall, the GPS scores in men who had a PIRAD 5 lesion were higher than those who had a very low PIRAD score of 1, 2, or even 3. But among individual patients, there was a risk stratification as shown by the vertical line here. So you could, again, take people and classify them better. And again, all of this is suited to just helping men and their doctors and their patients to make decisions that are appropriate for that individual. And the more you know, hopefully, the better the decision. So this is my final slide. And basically, this is another algorithm that I use essentially in daily practice. Again, not written in stone. But a patient, let's say, who comes to me, like I just mentioned, who has a grade 1 or Gleason 6 tumor, or perhaps has a Gleason grade 2 or 3+4 tumor, may be more adverse, but maybe not. So the first question I say, was their biopsy targeted? So did they have a fusion biopsy? If the answer is yes, but they have a normal MRI, then most likely that patient actually does have a low-risk tumor based on what I told you. I can take the option of using one of these tissue-based tests to actually confirm that the tumor is low risk, but generally speaking, that's what we would find. On the other hand, if a patient has a PIRAD 5 lesion, even though it says 3+3 or 3+4 on the biopsy, because even targeted biopsies are not perfect, in general, I actually recommend that patient be treated, but I also offer the use of a tissue biomarker like Oncotype, again, to confirm my suspicion that that patient has a high-risk tumor. But the meat of this is really for those who have an intermediate risk tumor on MRI, PIRAD 3 or 4. We really can use the tissue biomarker to risk assess whether that patient should be on surveillance versus be treated. So this is how I use this. Now, if the patient has not had a targeted biopsy and perhaps never had an MRI, the first thing I'll do is get an MRI so that I can then classify the patient like this. Here we have the option, of course, of repeating the biopsy in a targeted manner rather than just believing the MRI. And depending on the patient and the characteristics on the MRI, I may or may not recommend another biopsy. But again, we can go through the same routine. So I hope that I've shown you today how we are integrating new biomarkers, new imaging tools that have been developed over the last 15 years. Much of this work done at UCLA by my own group and by Dr. Leonard Marks's group, our Department of Radiology, our pathologists, all working together to both assess who should be biopsied and how to go about biopsying that person, as well as among those who have a diagnosis, who should be treated and who should not. So again, you have the opportunity to ask questions on Twitter using the hashtag here, or to make comments on YouTube, and I can answer some of those right now. So the first question is, I read that PSA blood test is still the best screening tool. Is that still true or arguable? I think as an initial screening tool, PSA is the best tool that we have. But as I've mentioned, not all men who have an elevated PSA necessarily have cancer. And back just 10 years ago, essentially, if there were 100 men who had an elevation in their PSA, only 20 of those men on biopsy would have cancer, and many of them would be overdiagnosed with a low-risk cancer that did not need to be treated. So the goal of these new tests is to essentially start with the PSA to assess, okay, here's an individual who is at some risk based on having an elevated PSA, and then say, okay, if the MRI is positive, we should biopsy that area. If it's negative, perhaps we don't need to do a biopsy and look any further. Or we can use the urine select MDX test, a blood test called 4K, which is another measure of PSA essentially, but a more refined measurement of PSA and other analogs, and other newer tests that are being used and on the horizon. So that's the first question. So PSA is still the first test, but it's not the end. So as a patient unfamiliar with advanced techniques, are these new imaging and genomic testing something I should ask my doctors for? I think the answer is yes. I think your doctor hopefully will be informed about the role of imaging as well as the different biomarkers and based on the recent literature from our group and others, how to integrate these things together. So I think that there's not a person that I see now with prostate cancer who we don't image, and many of them we use a combination of these different biomarkers to make an assessment of risk. So the third one is a more generic question, which is what are the warning signs for prostate cancer? Can I feel it? In general, the answer is no. Prostate cancer at an early stage, when it's curable, causes no symptoms. At advanced stages, kind of beyond what we're talking about here, it can cause pain in bone if it spreads to bone, it can cause urinary difficulties, and can cause a host of other symptoms. But generally, screening is done in asymptomatic men to identify cancer early and hopefully treat it early before any symptoms occur. And is research mature on these new tests? And I think the answer is yes. The data on MRI, which has now been around for 20 years and really has taken the forefront, is very mature at this moment. If you go to one of our annual urology meetings, at which and meetings around the world, MRI remains the hottest topic in this area. And then the tissue-based biomarkers and the urine biomarkers are all pretty well established, often covered by insurance, and I think are becoming more integrated into how we manage patients and should be considered. So with that, I'll end. Thanks for joining us on the webinar today, and feel free to contact me or my partners at UCLA, and the information is available to you. Thank you.